Diane here. So I'm making this video to do a comparison of how is it like being a nurse in England versus here in the United States. So I promised Matron Nikki, hi Matron, I miss you, that I'll be making this video for her. And I know it took me so long and now I'm finally doing this. Okay, so let's do it. Let's start with the basics. Hours of work. In England, I was doing 37.5 hours in a week, and here in US we do 36 hours in a week. Both are doing 12-hour shifts. So in England you do like three days in a week, but on the fourth week you do 4 shifts. And like here in the US, it's a fixed three days in a week work time. So schedule wise in England, I did mixed of days and nights. Unlike here in the US, if you are on nights, then you are on nights. That's a fixed night shift, which I like because I'm a night owl. I like doing nights. So that's for schedule. Uniforms in England, we wear the tunic and the trousers, which I'm pretty sure you've seen in Sister Nikki's video, and the dress too with a belt. Here in US we wear scrubs. Yeah, we wear scrubs. So doesn't matter in my hospital, it doesn't matter what color you wear, if it's matching, if it's not matching, if you want it with prints, without prints. So it's up to you as long as you're comfortable. It has a lot of pockets so you can move around. You can bend over, whatever you want to do. You can wear like undergarment to keep you warm. So yeah, you just have, I know it's hard. You might say, oh, how can you tell if that's a nurse, if that's an HCA or CNA, if that's a doctor? So we have like big IDs that shows like RN, so they would know if you're a nurse. So it's pretty easy to tell. So how can you be a nurse in England and in the United States? So I am an international nurse. So in England, before going there to work, we had to take the IELTS, which is the English exam, CBT, which is the computer-based exam. And then when I arrived in England, I had to take the OSCE. So after you pass the OSCE, then you'll be allowed to work as an RN. In the US, you have to pass the IELTS, which is the English exam, and the NCLEX. And now let's talk about salary. I know everyone wants to hear about salary. So let's compare. In UK, I started as band 5. My starting salary was, I think, around £13 an hour. And of course, as you do more years in NHS, your salary increases too. But up to a certain extent, there's like a top rate for band 5, which I think I left, my rate was about £16 an hour, and I did 5 years in NHS. So that's it. Whether you're working there for 10, 15, 20 years, if you've reached your max band 5 rate, then that's gonna be your rate. Here in California, I work here in California, so it really depends on what state you're living. So I can only share what I know just here in Cali. Their rate is much higher compared to other states. It's I think it's mostly because the cost of living here is a lot higher too, so they have to compensate with your salary. So my rate is a bit on the low side because I got here through an agency, and of course they process all my papers, this and that. So they gave me a little bit on the lower side compared to what they normally give out if you're non-agency. I heard that for new grads they offer around $50 an hour, and if you have more experience as a nurse, then they'll pay you more. They count all your experience. So let's say you have like 8-10 years of experience, then you're probably getting around $70 to $80 an hour, which is good money. So extra shifts in England, when you do bank shifts, in my hospital, the rate you get is the same as your normal rate. So if I get 16, my extra shift, I'll just be getting the same 16 pounds an hour. Here in the US, if they're really struggling to find nurses, they offer double time. So if I get like $40 an hour, I'll be getting $80 an hour for that shift, which is really good. If they don't offer double time, then most of the time they offer like time and a half, plus like incentives like additional $10 an hour. So yeah, really good money, although taxes are high too, but I mean, you get your refund anyway, so I think that's all fair enough, right? So that's it for salary. Okay, so let's talk about patient care. Nurse-patient ratio. In England, I was in AMU, a medical admissions unit, so the least number of patients I had was 5, and the most is 8. But if someone called in sick, like last minute, if you're unlucky and you're doing Bay H&J, you'll get like 10. But that rarely happens though. Here in US, especially in Cali, they have a law that the maximum number of patients a nurse can have is 5. So that's protection for nurses. So you won't get like overworked. So in my area, I work in med-surg unit, so that's the number of patients I have, just 5. And you have your HCA2, and for confused patients in England, we cohort them, and then we have a so-called tag bay. So you put all the confused patients there, and there needs to be someone always present in that bay, so someone can watch over the patients, especially those that are very confused and high risk for falls. Here in US, since we have, in my hospital, it's all private rooms. So it's hard because you can't cohort them. So what they do here is their beds have bed alarms. So you can put it on sensitive mode that when your patient is trying to get out of bed, it will alarm to all of the nurses on your phone, saying that, oh, 481 is trying to get out of bed. So everyone has to answer to that alarm and go to that patient's room just to check on that patient, whether he's trying to get out or not. And so each nurse here has their own phone. So say if your patient wants something, they press their call bell, you can call them straight from your phone and ask them what they need, especially if they're on isolation. It really helps because you don't need to go into their room. You can call them directly and ask them, hey, I'm your nurse, can I help you with anything, or do you want some painkillers and all? And that's, yeah, pretty convenient, right? So that's it for patient care. So let's talk about medication. So in England, we have our medication trolley where you have all your medication boxes in there, and we use our EPMA. So whatever medication we give, we just sign it off there on the tablet. Here we use Pixies. It's an automated medication dispensing system in the treatment room. So just put in your patient's name and it will show you what medications are due. So just click whatever you need to give, and each med will pop up like, get 1 tab of this, get 1 tab of that. So each medication has a barcode. When you go to your patient's room, you scan your patient's wristband and you scan the medication. So it's like, yeah, it's very convenient. It's like, doot, doot, doot. Yeah, it's like you're a cashier, right? It's pretty fun. And it will tell you if you're giving a higher dose. So it will alert, like, only give this medication. It's supposed to be like just 10 milligrams, but you're giving 20. So you need to cut it in half. So it will alert. So that's for safety too, right? For narcotics, in England, we do a 2-nurse check in the medication room. So you count them together and you sign the book together. Here, if you're giving the exact amount, you don't need a second nurse to check. You just have to make sure that your count matches the machines count. So that's sort of like your double check, especially when you're giving the exact amount. You only need a witness if you're giving a dose that's less than what the machine is dispensing. So if you're need to give like 1 milligram of morphine and it comes in 2 milligram, then you need another nurse to witness your waste. But otherwise, you won't need another nurse to check. For antibiotics like admixtures, in England we search Medusa, and then we check whether we need to mix it with 20 mils of water for injection, mix it and give it bolus. Here they want to limit our admixtures, so the pharmacy normally puts it in the fridge like pre-mixed. So you just get it in the fridge, it's already mixed, like 20 mils ceftriaxone, which you just give bolus. So very easy. And the rest of the antibiotics, we do IV piggybacks. So it's just mixing. They have like 50 or 100 mil saline bags with a spike that you just insert to the powdered vial and mix it and just piggyback it. So yeah, fairly easy. Okay, so let's talk about emergencies and patient monitoring. So in UK, when your patient is deteriorating, you can call the critical care team to come in and see your patient. Same here in the US, we have what they call the rapid response team, which I know means different in England. So here, when you call them, they come in and assess your patient and they guide you on what needs to be done and blah blah blah. Same with it's the same in England. Monitoring wise, in my ward in AMU, we do like DKA or AFib, patients with MI or patients with GTN infusion. So we handle them all in the bay, in the ward. So here in the US, they don't allow, if your patient needs like hourly monitoring, hourly sugar checks, then they can't stay on the ward. They need to go to a higher level of care like telemetry or intermediate care. They can't be on the floor. So we don't do DKA, we don't do GTN. I had a patient whose heart rate was high and she was in AFib. So I had to transfer her to a monitored unit, which is telemetry. So they can't stay on the floor. That's the good thing, because they get monitored more, unlike if they're in a bay with all your other patients. It's really hard to monitor them. I mean, even if they're attached to a cardiac monitor, you're busy doing like looking after other patients too, right? So I guess it's a lot more safe, I would say. The thing is, but the only downside here, I would say that in England we have doctors on the floor, especially in my ward. There are a lot of doctors on the floor. So if you have patients deteriorate, so you can call them straight away and they can assess your patient. Unlike here where I work in med-surg, there's no doctors on the floor. So it's just you. You can call doctors, but they base their decisions on your assessments. So you play a very big role on your patient's well-being. You have to do like a proper head-to-toe assessment. You have to really auscultate their lungs and this and that. So depending on your assessment, then they would base on how to treat the patient. So yeah, you really need to practice your assessments so your patients get, the right treatment too. Yeah. Okay, so let's talk about culture. So here in California, we get like different nationalities too. Same in England. So it's really good that it's like diverse. You get like lots of Mexicans, you get African Americans, you get Asians, Filipinos, Americans, so a lot. So same in England, it's pretty diverse, which is good. They're very open. You don't see a lot of racism, which is good. Yeah. All people are nice. Although when I started, I felt that someone's really mad. Anyway, so yeah, it's just that here they're more straightforward, which I'm not really used to. So I'm still trying to get used to it because I've used in Britain, all people are nice there, and you know, they always say, "Oh, bless you." Yeah, but here they're really straightforward. They say what they need to say. So yeah, which is I think good, and it can be good in some ways. Um, but here I think they expect you to be more independent. Um, they're not going to treat you like a baby. I had my shadowing or my mentoring for just 2 weeks. Imagine, I'm just new here. Everything's new to me. All the systems are new. So everything's computerized. All the documentation, everything is computer. All the orders, everything's like computerized. No, we have paper charts, but we don't really write our nursing narrative there. So they gave me just 2 weeks of orientation, so like 6 shifts. After that, I'm on my own. I asked to be extended. They only gave me 1 day, and that's it. You're on your own. Unlike in England, I think they gave me like 4 weeks, and you can extend like whatever. If yeah, if you're still not comfortable, then they'll give you that. But here, I mean, they'll expect, especially if you're an experienced nurse, they will expect that you would know what you already know what you're doing. So yeah, like first month of being here, I was like, oh no. I don't even know what I was doing. But I think, yeah, you have a lot of good co-workers, good colleagues that will help you. So, and a lot of Filipinos here too, like 80% of my colleagues are Filipinos, especially during the night. So very helpful. So that is it. So I don't want it to be too dragging. So I just made like a quick comparison of how it is, just the basics of how it is working in England and here in the US. I can't really say if I like it more here, if I like it more there, although I have all my friends that turned into families in England, which are very close to my heart, and I miss you all so much, so much. So yeah, I'm just on my 5th month here, so can't really compare just yet. Just the basics. That's what I can tell you. So I hope you learned something, and yeah, hi Sister Nikki, I miss you. That's it. Thank you.